Well, welcome to the Ohio Prior Authorization webinar. I'm Pam Fields, the State Director, Advocacy and Access for the Arthritis Foundation. You will be on mute throughout the presentation, and Julie, if you could forward the slide, thank you. Please, if you have a question, use the Q&A feature to send us your questions. And at the end of the webinar, we'll address them, and Julie will be handling the Q&A questions for us and refer back to your speakers today. We're excited today to have with us Platinum Ambassador, attorney, and parent Meagan Faust, who will share her family's challenges with the prior authorization process. And then we'll move directly into Tim Maglione's presentation. Tim is the Senior Director of Government Affairs, Ohio State Medical Association, who will be our featured speaker. Meagan?
Hi, good morning. Thank you, everyone. I appreciate being invited to speak on the webinar. As Pam said, I am a JA parent, and as many JA parents know, the time from initial symptoms to increased pain for your child to an unwillingness to walk into a final diagnosis can seem like you've been put into a time warp, and it can last a lifetime. You feel really out of control, at least that's how we felt. But finally, when we had a diagnosis from our doctor and a treatment plan, I, as a parent, felt like I had some control back and I could take some steps to move forward to help my daughter. My daughter was diagnosed at a very young age, so it was difficult to see her go from a happy-go-lucky, rambling toddler to one who really did not want to move. She sat on the floor pretty much all day as the symptoms increased. So once we got our treatment plan, initially the doctor had said she had less than 3 joints afflicted, so we were going to start on steroids. And we were to come back and see him in a month, 3 weeks to a month. In that time frame, from the initial diagnosis to going back to checking in with him, her joint involvement increased significantly, and we were in excess of 10 joints at that point in time. Obviously, the steroids were not doing their job. The doctor wanted to get more aggressive and give her some immediate relief. So the treatment plan changed from steroids to bring her into the hospital for joint injections, and because they had so many joints they were going to put her under anesthesia and do it with radiology to guide the needle. We thought, great, this is good, we'll get this scheduled. We, in fact, had it scheduled for a week out. 3 days later, we received a call from the doctor's office indicating that we had to put her appointment on hold. My husband and I thought that we were doing really well and we were really smart because both of us are full-time employees, and we both obtained insurance coverage through our employers, so we had our girls double covered. Unfortunately, that gave a kind of a loophole that we had to go through, or a glitch, in that both insurance companies had to give prior authorization for the treatment plan, which was aggressive in the anesthesia, and go through some history. And unfortunately, neither one of the insurance companies had the same processes and procedures, so the doctor's office had to fill out forms differently each time to go through the process. One of the insurance companies came through fairly quickly with the prior authorization, but unfortunately the second insurance company did not, so we were delayed even further getting through the process. Her initial diagnosis was in the late fall, so we were moving toward the holidays. When we finally got the authorization from both insurance companies to move forward, the soonest we could get an appointment to do the procedure was after the first of the year. I felt great. We were moving forward. I had some control, some power in what to do. Unfortunately, kind of as it seemed as to be a perfect storm, my employer had changed health insurance providers, and the new insurance carrier went into effect on January 1. We really didn't think much about it when we were going through the prior authorization, but come January 1, getting ready for the procedure, I submitted the new insurance information to the hospital, and we were having to hold up yet again because the new insurance carrier wanted to go through its own prior authorization, and unfortunately they wouldn't accept the investigation and the forms that were handled and approved by the prior two insurance carriers, so we were delayed even further going through. We finally did get her in, and by the time we had the procedure done, she had 14 joint injections done in one day. So she had moved from less than 3 joint injections at the time of initial diagnosis to in excess of 14, and 14s were done in that one day. Prior authorization processes, while I understand them for the insurance companies, they do and did cause us delay and additional stress and pain for my daughter. Some of the other issues that we've had to deal with prior authorization are in a job. I've been employed with the same company for quite some time, very happy with them. But as everyone knows, when you start looking, jobs come up, and a dream job came up for me and an opportunity for it several years ago, and I started looking into it. Well, as opposed to looking at what is my compensation going to be, what type of work am I going to be doing, who else am I going to be working with, those types of things, I focused on the health insurance. Having gone through changing health insurance through my own employer once, I was fearful of changing jobs and having a whole new company, a whole new health insurer involved. And sure enough, when I started doing my investigation, I talked to the HR person, I talked to somebody at the insurance company as well. Obviously, my daughter would have to go through any prior authorization for any subsequent procedures, but I also found out that as part of their prior authorization process, they went back to a step therapy or a fail first. So at that time, my daughter had been undergoing treatments for about 8 years, and we had been through a course of about 6 or 7 different medications, if not more. And I was told that I could not put her into the same treatment plan probably that she was on that was working at the time. Instead, the insurance company would want her to go back and try other methods of treatments, other medications that she had already utilized, and we had taken her off them because either they were ineffective or she had significant side effects to them, but because she hadn't been on them or tried them for the past 2 years, they would have to try those first. So with that fear in my head, I stayed where I was. I'm happy at my employer, and it wasn't terrible, but it definitely gives me as a parent the feeling that I'm held hostage by an insurance company to move forward with, looking at prior authorizations. If the prior authorizations at the time I was looking at this, had they been standardized, had there been some ability to, the companies could rely on each other, what the investigation was done, it probably would have helped and made it easier for us to move forward. So that's my story in a nutshell. We've had other issues with prior authorizations, but that's probably the one that was most impactful for us as a family starting out through this journey.
Thank you, Megan. Tim?
Yeah, thanks, Megan, for that story. That is exactly the reason why we at the Ohio State Medical Association really put together this legislation to try to make the prior authorization process more efficient and more timely so that you aren't experiencing these delays in getting answers about whether a treatment is going to be approved. So a couple of the things that you mentioned also relate to step therapy. And while this specific webinar today doesn't get into the details of step therapy issues, there is separate legislation pending in the Ohio legislature today to really reform how step therapy works. And I know many of the advocacy groups on this call are a part of that effort, and I hope to get some movement on that legislation through the State House here in the next month or so. And we'll save that topic for a later date. But for now, let me talk about the new prior authorization law in Ohio. As you all know, prior authorization is a process where doctors have to ask insurance companies really for permission to perform certain procedures or prescribe certain drugs to determine whether or not, in fact, they'll be covered. So prior authorization, a lot of people use the initials PA to designate what is a prior authorization. I think PA in some cases really means prevent access by the insurance companies. And this is really an important issue to patients, not just providers who do much of the paperwork and the administrative side of this thing, but for patients in terms of getting answers quicker about your needed services or medication. So for every hour a doctor spends with a patient today, we know they spend at least 2 hours on administrative tasks like prior authorization. Think about that. Not hands-on patient care, but the administrative tasks of dealing with the multiple insurance company sets of rules. So that's why this is really important to patients. It will free up doctors have more time with patients. So we heard a lot of stories about the problems with prior authorization, and we went to the legislature and said, look, we got to do some reforms that make this system better. We worked with Senator Randy Gardner and Senator Capri Cafaro on this. They were the main sponsors of this legislation. Moving on to the next slide. What we did, and I thought was really, really important to the success of this, was put together a very broad-based coalition of patient advocacy groups from medical associations, other provider organizations, and as you can see from this list, including the Arthritis Foundation and many others, this is an impressive list of advocates that all spoke in favor of this legislative effort. And when you're at the State House and you're lobbying on a particular issue, having the breadth and the depth of a coalition like this was really, really helpful. So, moving on to the next slide, we can kind of get into some of the provisions of the bill that specifically relate, I think, to some of the interest of patients and certainly to the interest of the provider community. So, the law was broken up into two different segments in terms of when the new provisions would become effective. So there were a certain set of segments that became effective in 2017, and there are new provisions that will become effective in 2018. For 2017, for providers, insurance companies are going to have to make their rules much more transparent in terms of what requires prior authorization. And the idea behind this is that if we know what the rules are in terms of what requires prior authorization, what supporting documentation is needed to accompany the prior auth request, we're going to have at least a pretty good chance of getting that information into to the system, thereby avoiding the delays. So that's really important. And if they change the rules in terms of what requires prior authorization, they're going to have to give the providers at least 30 days advance notice before those new rules go into effect. And again, why is this important? This is kind of an interesting cartoon we saw. I've been on hold for 30 minutes. I've had 12 transfers, and now you're telling me this doesn't even require prior authorization. So keeping up to date by the health plans in terms of what actually requires prior authorization, I think is going to be really, really important. So for patients, this transparency also applies when you sign up for a health plan or are looking for choices of different health plan options. It's really important to know whether or not particular procedures or medications maybe that you're currently on have a prior authorization requirement. So this bill specifically requires the insurers to make this information available to patients that clearly identify those policies and specific services and drugs to which a prior authorization requirement exists. They have to make that available on their website. So that transparency, I think, is really going to help patients in terms of knowing what exactly requires prior authorization. And then you can decide whether or not that might be maybe a different plan that you would want to look at for your condition. With the next slide, one of the things that's really important as well is, a lot of times doctors and patients will navigate through the prior authorization process. They'll actually get an approval for a particular medication or a service, and then lo and behold, 6 weeks later, you get a letter in the mail saying, we're sorry, we're going to retroactively deny this. And so we put a provision in this legislation that will prohibit these retroactive denials. So if you get an approval, it's going to mean that it's really approved. There are some provisos and qualifications to make sure that requirement is met. The patient has to have been eligible. An eligible enrollee in the health plan at the time the service was provided, the condition didn't change, and the information that the provider submits in terms of what they did with the patient matches that which was approved. If you meet that criteria, there is an absolute prohibition by the health plan from coming back later and retroactively denying something that they previously approved. So there's a significant patient protection. Also, something called retrospective review. This is more related to medical procedures, and one of the examples that we used on this is that, let's say you're going in for a knee surgery, and the doctor thinks it's a torn meniscus, and that's what they get prior approved to get fixed. But they go in to the knee, and during the surgery itself, they find out that there are other things that are damaged. Under this new provision, they're going to be permitted to fix those other things, and it won't be denied later for lack of a prior authorization for those new additional things, as long as it was not known at the time the original prior auth was requested that those services were needed. And so, again, it's a nuance, but it's one of those things where you get protection if the doc needs to do something that was unanticipated in conjunction with something that was already approved. They're going to be able to do that, and the health plan won't be able to later deny it for lack of a prior authorization. This next provision is really important for people that have a chronic medical condition. And I know a lot of the advocacy groups on the call, these are obviously conditions that relate to, the spirit of your advocacy work. What we wanted to try to do is that for folks that have a chronic condition, rather than having to get a prior authorization every month for the same medication or for the same treatment, we know these chronic conditions are probably not going to change. They're going to last a long time. So why not set up a system where a patient can get a year-long prior approval? And so it sets up the opportunity to get that done. Now, the insurance industry didn't like this, and they put a lot of qualifications in terms of how the year-long process would work. And if we go to the next slide, it'll indicate some of the limitations. So you can't get a year-long prior approval if the medication is for a non-maintenance condition. Well, most chronic conditions, when you're getting a medication, it's for the maintenance of that chronic condition. So that hopefully won't apply too often. Obviously, if it's a treatment that lasts for less than a year, that wouldn't apply either. They may have a trial period to determine the effectiveness and a few other circumstances. But the bottom line is, for most individuals that have a chronic condition, they're going to be able to get a year-long prior approval. There was a separate section that said that the insurance companies may, but they're not required to, also have a 12-month prior authorization for people with rare medical conditions. And a rare medical condition means a disease or a condition that affects fewer than 200,000 individuals in the United States. And so under that circumstances, the payers may, but they're not required to, have a year-long prior approval for people that have what's considered to be a very rare medical condition. Moving on to the next slide. These are the provisions that are going to become effective in 2018. One of I think the most significant for the provider community is that the insurance companies are going to have a web-based system through which to receive prior authorization requests. Right now, a lot of prior authorizations have to be done by telephone, where you can sit on hold for minutes, if not potentially hours, or faxes that somehow mysteriously get lost or never received. And if we move to a web-based system to submit prior auth, we can really avoid a lot of those delays. And so this system sets up that mechanism for the provider to submit these via the web. This is really going to save a significant amount of money for payers and for providers. As you can see in this, the cost for insurance companies to process an electronic prior auth is only 4 cents. where a manual would have been $3.66. So all these things that the insurance industry said, this is going to raise the cost of health insurance premiums because we're going to have all these new regulations. Well, the bottom line is it's going to cost the insurance companies less to process them if they do it via electronic web-based system versus the manual telephone and fax scenario. Same savings go to the doctor's offices as well. Next slide. We're going to get faster answers, and I think as Megan mentioned, some of the delays in getting answers is really frustrating when you have a situation that you need to have addressed in a timely manner. Faster turnarounds for urgent matters, it's going to be 48 hours. And for non-urgent matters, it's going to be no more than 10 calendar days. And all of the things that occur in a prior auth request, whether it's the doc getting back to the health plan with additional supporting documentation, whatever has to occur, all of that has to happen within either that 48 hours or those 10 calendar days. Next slide will really, I think this was really important to us. When we talk about an urgent matter, which is then subject to the 48-hour turnaround time, obviously those are things that can seriously jeopardize the life or the health or the safety of the patient, or in the opinion of the health practitioner, and this is really important that we got this language in the opinion of the practitioner, that a delay would subject the patient to adverse health consequences. This isn't up to the insurance companies to decide whether it's urgent. It's up to the practitioner to decide whether it's urgent. And if it is, then the 48 hours kicks in. Next slide. To give you an idea of how this is a little better, well, actually a lot better than the current rules that the health plans work by. The NCUA is their accrediting organization that sets time frames for utilization management. And you can see that the Ohio law is much better than what NCQA has in terms of the time frames. So moving on, for the physicians, they're going to get more clarity if a prior authorization is denied. For whatever reason it is, the health plan is going to have to give a specific reason. And I think that's really important because a lot of times they just come back and say denied. You say, well, why? And then you got to fight them to get the answer on why. This is going to require, if they deny it, the health plans to give specific reasons for the denial. For appeals, and this is where a prior auth request has been submitted and it's been denied. The insurance companies, like I said, are going to have to give you specific reasons why it's been denied, but you're going to be able to appeal that decision, and those appeals will have similar time frames to the initial request time frames that I've talked about. So 48 hours to get an answer on an appeal, and 10 calendar days to get an answer on a non-urgent matter. So as, again, you can see the NCQA significant differences, particularly in the non-urgent matters, where they have 30 days to answer an appeal, where under the Ohio law, that's cut down to 10 calendar days. The interesting thing, and what we thought was really important too, is if there is an appeal, who's the appeal going to be within the health plan's utilization management system? Our view has always been that appeal needs to be by a clinical peer of the practitioner that's recommending the course of treatment. So if your doctor says, this is what we think is necessary, and the health plan says, no, we're not going to approve it, you're going to be able to appeal that decision, and a clinical peer who is somebody that is in a like or similar specialty as the physician that's managing the medical condition. So, if it's an orthopedic surgeon looking to do a surgery, it's going to be an orthopedic surgeon on the other end of the phone with the insurance company where they can have that peer-to-peer discussion. There used to be situations where you'd get a general practitioner maybe reviewing the recommendations of a heart surgeon or a neurosurgeon. And obviously, the expertise that they have is clearly different. So if you go through all those, the appeals process, and you still don't get an answer that you're satisfied with under a law that was passed probably 15 years ago, you can appeal that to an independent organization outside of the health plan, and an independent medical review will occur under that circumstance. So there's that opportunity to get to an external appeal as well. So just real briefly, some other components of the law. It's going to apply very broadly to all Ohio licensed health insurance corporations, what they call sickness and accident insurers, and also to the Medicaid managed care plans. And that was really important for us to make sure the Medicaid managed care plans were brought under this law. Now, unfortunately, we exempted from the law are certain entities that Ohio just doesn't have the jurisdiction to regulate, because they are regulated by the federal government, and those are self-insured third-party administrators and Medicare Advantage plans. We can't, as a state, regulate them again because the federal law preempts the regulation in those two particular areas. So finally, the question is, all right, so we got all these new sets of rules. What happens if the health plans aren't complying with them? Well, in the legislation, we set up a mechanism where you can file a complaint with the state insurance department, with whatever the problems are you're having or the physician is having in getting answers or compliance with the law. We've provided some links in the PowerPoint to do that, and there's a consumer hotline as well if you want to make a phone call to the insurance department. But I would absolutely urge all the advocacy organizations, as this law becomes implemented, if we're not seeing compliance, we've got to file complaints with the insurance department. That is the only way that the insurance department responds to these non-compliance things. They don't do random audits on their own. They're really more of a complaint-driven system. So if we're not seeing compliance, we need to have those complaints filed with the insurance department to get the insurance companies to do the right thing. So, next slide. I think at the end of the day, really what this bill is about, it's about transparency and what the rules are. And again, if we know the rules, we got a much better chance of complying with them. It's about efficiency. We're going to get answers quicker, faster turnaround times on the prior authorization request, and really about fairness. If you get through the prior auth process and it gets approved, they really shouldn't be able to come back and retroactively deny the system. So really, we just flew through about 15 minutes of what took about 2 years to get through the legislature, hundreds and hundreds of hours of negotiations and meetings with lawmakers and the insurance industry and our advocacy groups. But at the end of the day, this particular bill really is now being touted as a model across the country on how to do prior auth reform to get that transparency, to get that efficiency, and to get that fairness. So I will stop there and just see if there are, at this time, Pam, I'll turn it over to you for concluding remarks and see if there are any comments or questions.
Thank you so much. I want to extend special thanks to you, Tim, for taking time to share your insights with us. That was really, really helpful and will be beneficial to all of our advocates. And I want to thank Meagan for sharing her story. I know there's more to that story, and I appreciate all that you were able to share. Also want to thank our bill sponsors, Senator Gardner and our former Senator Cafaro, for their tireless efforts to find compromise. And I know that those many hours are accurate. Thanks to our coalition leader, the Ohio State Medical Association, and all of our coalition partners, many of whom are on the call. And finally, to the grassroots advocates and ambassadors who made calls to their legislators, testified, sent emails, and attended Capitol days. You are greatly appreciated, and you are our heroes. Julie, if you would like to take over and run the
Sure, thank you, Pam. asked is, does a serious and persistent mental illness qualify as a chronic issue for the 12-month prior authorization? And Tim, I'm going to direct that question to you.
We didn't really get into specifics about the types of conditions that would qualify as a chronic condition. The statute essentially defines a chronic condition as any medical condition that has persisted after reasonable efforts have been made to relieve or cure its cause and has continued either continuously or episodically for more than 6 continuous months. So it seems to me that what you described, if it has continued for 6 continuous months, that I would make the argument that that meets the definition of chronic condition.
Great. I've got 2 more questions. This one is there anything in the recent legislation or elsewhere in the law that precludes a provider from going forward while awaiting a prior authorization, provided that a patient or a family chooses to go forward and that they are willing and able to pay?
So there's nothing that would preclude the provider from providing the service waiting on the prior authorization approval. There may be, within contracts that providers have with the health plans, some restrictions on that, but as you kind of mentioned, if the family is willing to, suggest that they would be financially responsible regardless of whether it's approved or denied, I would imagine most physicians and other providers would be willing to move forward.
Perfect. And we have one final question. If we could just reiterate some tips for patients to help them achieve successful decision or to work around the process beyond just talking to insurance commissioners about complaints, what other ways can patients be proactive?
Well, I think awareness is the most important thing. This is really a new law, and not having many of the patients understanding that the benefits of this law are available. And I think that's where the advocacy groups the patient advocacy groups can really help in spreading the word that these new protections are available, and that if they see things that aren't going according to what the law provides, that complaint system is really the way that we're going to get issues resolved. So I think spreading the word by the patient advocacy groups is important. We are doing that with the physician community and letting them know that all of these new rules are available, and that if there are bumps in the road, obviously the provider and the patient can work together in terms of getting these complaints filed with the insurance department.
Thank you so much, Tim. I think that really covers all of our questions for today. The other comments that we've received have been overwhelmingly positive. Thank you for all of the hard work you've done on this legislation, and we think it really is going to be a significant improvement from before and a great start. So thank you for joining our call today as a speaker, and to our attendees, thank you for joining us and learning more about these new prior authorization protections. We're going to have a recording of this webinar posted on our website early next week for your access, and so you can share it broadly so that we can do just what Tim was saying, raise awareness from our patient advocacy organizations about these new protections and how patients can interact with their healthcare system. So thank you to everyone. Thank you to Megan and Tim